Hi there, everybody. Welcome to this session online, which is going to be about non-muscle invasive bladder cancer and radical cystectomy. My name is John Aning. I'm a urologist from Bristol who specialises in the management of bladder cancer, and I'm really excited and fortunate today to be joined by my colleagues.
Thank you, John. I'm joining today as well. My name is Carmen Mir. I'm a urologic oncologist. I work in Valencia, Spain, and I also specialize in bladder and kidney cancer.
And thank you. My name is Marco Moschini. I'm a urologist in Milan and San Raffaele Hospital. And as my colleagues, I'm also specialized in bladder cancer.
Well, look, what we're going to do today is we're going to take you through really the high-risk non-muscle invasive bladder cancer disease, and then talk about the management aspects in more detail. And I think let's go straight into it. So, I mean, Carmen, if I can start with you, I mean, the dilemma here, what are we talking about when we say high-risk disease?
Yeah, so high-risk disease has several definitions. EAU guidelines do provide a clear definition. However, for urologists, it's very difficult to draw the line when to trigger for cystectomy. No? Mm-hmm. If you think about it overall, I would say for non-muscle invasive, it would be an overkill to think that all the patients should go through it.
Yeah.
But I think it's more of a discussion, and it's patient preference, comorbidities. There are a lot of issues that are to be taken into consideration when we think about non-muscle invasive high-risk patients to trigger for cystectomy.
Fair enough. I mean, Marco, from your perspective, are there any things that give us more high-risk features that mean that you are worried about patients with non-muscle invasive disease?
So I think it's very important to consider the European guidelines. As a member of the European guidelines, I would say that one of the quality of the European guidelines is that they make a sub-stratification for high risk and very high risk. And this is something that, for example, for the IBCG classification is not present. And particularly, the European guidelines say to us that if the patient is older than 70 years of age, if its tumor is bigger than 3 centimeters, or if there are multiple papillary tumors, these are all features that, together with the presence of high-grade disease that could be TA, but most particularly T1, or the concomitant presence of carcinoma in situ, or lymphovascular invasion, or variant histology, these are all parameters that can help us to guide in the sub-definition of very high risk, which are all the patients that are actually at very high risk of progression, and so that they need to be treated more aggressively than all the other patients that are just high risk.
And look, I looked at the guidelines in depth before we did this session. You know, every year the guidelines get better in terms of the content and in terms of the clarity. But when we look at very high risk and high risk, clearly what we want to know for our patients is the risk of recurrence, but more importantly, the risk of progression. Carmen, I mean, what do you think about that?
Yeah, if you actually, there is some data that is very interesting in that specific area. If you ask patients what bothers them and what is important, how much risk are they willing to take in terms of progression, it's interesting because they all most of them, they answer that they are willing to delay their cystectomy in order to take up to, I think it was like 40 or 50% risk of increased risk of progression in those terms, which is interesting. So it's somehow difficult to evaluate, you know, because it's more of a patient preference, as I said at the beginning.
I think for us, that's why this discussion today, and as we go further into the topics, it's going to be more both in terms of practice and examining in more detail how we factor in that patient feeling about the treatment options against the oncological aspects. That's really critical, and it's the hard thing for us to do in our clinic room. So, I mean, just thinking about from a non-muscle invasive bladder cancer perspective, are there any patients that you would absolutely go, there is no choice, you should have a radical cystectomy?
I mean, no patient, no. I think Marco mentioned the same. No patient wants a radical cystectomy.
Yeah.
Definitely. Actually, we have some data from the UK from a randomized trial that aim to generate some data in terms of feasibility, the Bravo trial, to figure out if we could actually argue to compare the both, like going for bladder sparing versus going for a radical cystectomy in this setting. And he told us that would be very hard to actually randomize. I think it's more than 60% of the patients actually decline their randomization because of patient preference. So it's a difficult area of the disease to actually figure out how things work.
Yeah. No, I think you're right in terms of the randomized control trial situation. It's super difficult to study this, and what we do in our clinic room probably is the easiest, and the PROM data, because Jim Cato's got some great data as well on this patient group in particular. Marco, I mean, from your point of view, are there any patients who you would go, I think you should have a cystectomy?
So regarding the stratification, because I think it's important to divide the topic into. One is the risk of progression, as you correctly said. And if you consider, again, the guidelines, we have the RTC table, or we have the Cueto group substratification. But all of these are based on, I would say now, very old data. And if you try now to replicate them and to put this patient in the actual world, we are actually probably better than what we were before, because there are several ingredients in the bladder cancer that are how good you are in performing TURBT, but also how good you are to stick in the 3-year maintenance, for example, for BCG in the high-risk subgroup. And I think we improved as urologists in this thing as we were 10 or 20 years ago. So probably even if you counsel the patient with the current stratification, you are not doing the right thing, because probably now the result could be slightly better than how it were. And then I come to the second point, which are actually the symptoms to the patient. So from a perspective, oncological perspective, I would say always now you have to offer alternatives to radical cystectomy. But if you have a specific patient with very high burden disease, with a carcinoma in situ, with LUTs, very important LUTs, and a very low quality of life, this is the only situation where you probably want to consider an immediate radical cystectomy, and is the patient asking for it, because it's bothered more from the symptoms than from the oncological risk that might be under control if you do all the right things.
Okay.
Actually, since you mentioned that, to me it's interesting, the data that came out at AUA with a cystoprospective registry, that was very mind-blowing, I would say, because we would have expected they look at the patients if they were happier in terms of quality of life with cystectomy versus having bladder-sparing treatments. And the result was contradictory to what we would have expected, since they said quality of life with radical cystectomy was actually better overall, not in the sexual side of the component of the questionnaire, but what was more interesting to me is that the ones that actually benefit the most are the patients with CIS, that are most of the time the ones that are symptomatic. So these patients were actually appreciated to go to the cystectomy much earlier on on this timeline than you would have thought. So,
and I think that's really important for us to consider, isn't it? That actually what patients want and how they feel. We know that radical cystectomy is a big operation and it's morbid, but the reality is that actually down the line, patients do sometimes know where they are. So I think it's an important message that plays out.
To me, I mean, another reason for cystectomy would be variant histologies. There's always some uncertainty in that setting. We have contradictory data. We're getting more used to it. We have more data coming out about how are the outcomes of these patients, but overall it's challenging because we don't really know how these variants behave in this setting. There is very little data on that.
I mean, just sorry to interrupt, but I think it's so important, and it's great because you're here and you're experts on not only the evidence but the guidelines and how we give practical advice. And you know, I was studying the guidelines, and I think it's very clear for the audience. So the EORTC tables, I mean, they're for patients without BCG.
Yeah, that's one of the issues.
Exactly.
Right.
and the Queto table is with BCG, and I
So
think
the data is a little bit of an overkill because
Exactly.
probably with BCG, there is some MD Anderson data actually that shows that if the same subgroup of patients of EORTC are treated with BCG, that would be our standard of care currently. The progression rates are probably half of what is reported by the EORTC tables.
Absolutely. And Marco, any comments on that?
No, I think that is what is missing always, and in the past was missing is the patient involvement. That is fundamental. And regarding the histological variants, I totally agree with Carmen. I would also like to stress the importance of having a good pathologist that you trust in the diagnosis. This is something that we do in our hospital, is to make a revision of the pathological specimen if the specimen is coming from a local hospital, because we had the experience that local pathologists without a specific expertise in urogenital tumors or in bladder cancer tend to miss the variant histology.
Right.
This is something that we want to know. If the patient has a variant histology, for example, if it's a sarcomatoid tumor, would be for me an indicator to go strict to radical cystectomy. But if there are other type of variant histology, always also knowing the percentage, if it's less or more than 50%, I can adapt the strategy and to understand if the immunotherapy could be the solution or if we can offer other strategies like chemotherapy in this patient. And it all depends from a good pathological evaluation, and you need to trust your pathologist. Otherwise, it's impossible to make the decision.
For me, another trigger is also that you were asking about the red lines. No? It's like patients with high-grade T1 when they are BCG unresponsive and they get another high-grade T1 within 3 months. For me, that is a red line I would not cross because your chances of being upstaged are so high that the risks are over. You have to balance, as we said. But for me, it's like definitely I encourage them for cystectomy in that case.
But I think if we take a step back then and let's talk about the impacts of the treatments that we have that are guideline recommended that have on quality of life. So if we talk about BCG, okay. So I mean, in terms of the side effect profile, in your experience and with the evidence, Marco, I'll start with you and then we'll come to you, Carmen. But is it well tolerated?
So I think there are side effects with BCG, and it might be also for the side effects slightly better than we thought in the past, but definitely we all have experience of patients complaining about side effects and some of them requiring to stop the instillation. And I think it's crucial for us as a urologist to explain to the patients the importance of the treatment, especially because we were not so good in maintaining the patients in the maintenance treatment. And this is a huge problem, because if the patient is not completing the maintenance, then it belongs to categories, in case of recurrence, that are actually difficult to understand if it's possible to offer further treatment, to do rechallenge, to do eventually clinical trials. And so that's an important part, and I think the cooperation, again, with the patient will also reduce the complication and the side effect of the BCG, because we'll let the patient know the importance of the BCG, not just to suspend the BCG, the treatment after some dysuria, which can unfortunately happen very often, and also to be ready to treat even with antibiotics in case of side effects, properly, of course, not just giving antibiotics randomly, but in case of prostatitis, cystitis, something that can happen with the instillation, to treat it properly, and the discontinuation rate in the proper setting would be not that bad as it was thought in the past.
Okay. So, I mean, Carmen, when we look at the randomized control trials, I mean, at least 30% of people came off the BCG, even in the trial schema. So, in terms of real-world evidence, are you aware of any evidence, or is there anything that you discuss with your patients about the side effect profile of BCG?
Yeah, so I personally think we do at least in my case, very poorly at evaluating the symptoms. Sometimes we defer into the nursing side of our team to evaluate it, and we are not as proactive as we should be. Probably, as Marco mentioned, if we were more proactive and we would ask more in detail about hematuria, how are you doing? Have you had any fevers? You know, all these little things that can help the patient understand what he should look for. We might do actually better in terms of prolonging how long they are on the BCG treatment.
And Carmen, you always inspire me. So with your nursing team and everybody else, I mean, do you engender that in them? Do you bring them to the EAU regularly so that they can be updated? How do you make sure that all the team that's delivering the care sort of...
Yeah, so for us it's difficult, but it's always a language barrier.
Okay.
Right. So for the nursing team, in my case, EAU is challenging, I would say, because of the language barrier. It's getting better now with online translations and, you know, getting more involved in all these evaluations. However, it's been so far a little bit challenging.
Okay. So that's certainly more work for us at the EAU.
The other thing I wanted to mention, I mean, there's also, I mean, as I said, we do poorly. However, if you look at some data that has come out in terms of quality of life, how do the patients with non-muscle invasive do if you ask them, like on a regular basis with regular questionnaires, their quality of life is actually not decaying. They are pretty happy in it if they understand what is happening.
Okay. So just talking about quality of life, so we've talked about BCG, so that's an established treatment. Can we just go across to surgery just for a minute and talk about robotics? I mean, Marco, I know you do robotics. What proportion of your radical cystectomies do you do robotically?
I do 100%. Of course, there are patients, but now it's very limited. I would always give the indication from the oncological perspective to the robotics. Also, I did recently a T4 disease, and I think always is better robotic if you are able to do robotics. If you are a very good open surgeon, you should do open surgery. The only situation when I had some problem is with very, very overweight and fat patient because they were not able to stay in the Trendelenburg for many hours. And so we prefer to do it open. But I think that even in this patient, you definitely see better with the robotic if there is no anesthesiological contraindication.
And in terms of quality of life afterwards, do you use quality of life measures in your patient group in routine clinics? Or?
Yes. We have, as a high volume center, in our center we have a dedicated outpatient clinic where we see the patient before the surgery. We make all the counseling also with a stoma therapist, with a psychologist, which I believe is very important, especially to the self-acceptation of the stoma, if needed. And we deliver to the patient a book with all the information, all what expected. And then here is very interesting because there are patients who really want to know everything, wants to read everything. And there are patients who just say, no, please take this book away. I don't want to do anything. Just do what you think is better for me. And you have to accept all the type of patient, and you have to be able to measure these things. Then we do the surgery and we do the reevaluation, and we have questionnaire also for regret.
Okay.
Regret from the surgical perspective. Also the surgeon sometimes ask, okay, do you have a regret by doing the surgery, by deciding this reconstruction? And also we ask to the patient. And what we found out is actually if you explain to the patient very well and you do the proper counseling, and that means also not doing the cystectomy sometimes. If you realize that the risk of the cystectomy is too high, you should say, no, I'm not doing the cystectomy in this case because your mortality risk is 90 days, is that. It's too high, I don't want to accept that. And that I think it's important to offer to the patient. In this case, you can really make the difference for the patients.
I think in that same sense, for me, it's very important in the pre-surgical, the frailty assessment. Oh. That is a key component because our patients are mostly over 70. Yeah. And they have a lot of communities, and then we don't do a good job at figuring out how they do in their daily activities and how much help they need from their surrounders.
I think that's so important. How do you do it then? How
Exactly.
do you do it?
I was going to say, to me, sometimes that's what I do. I just walk out of the clinic with them and talk to them for a little bit, like when you go upstairs.
Yeah.
It's an easy, cheap, and fast way to figure out, okay, he's doing well or he's not doing well. You know, if he cannot even do that, then probably he needs further assessment before he goes to cystectomy.
Yeah. No, even that short walk to the clinic room tells you so much, doesn't it? So, I mean, I just staying on that sort of theme. So, with the impact of robotics, we've talked about that and how that changed. We've talked about frailty and how we assess the patients. Do you support the patients afterwards with any kind of survivorship in bladder cancer?
So in my case, in Spain, this is just starting, actually. It's just the first association of bladder cancer patients just kicked off.
Okay.
Until now, it was hard again for the same thing, the language barrier. You have a large population that does not speak English, and so far, like the most common one is BCAN, the most known one in the US for patient association and support. So it was always a language barrier for our patients. But I think right now we will get better with this new association.
No, and Marco, again, it was a place in the discussion that I wasn't expecting to go, but you mentioned neobladder. And so we've got non-muscle invasive bladder cancer. We clearly have the risks associated with neobladder. How do you select the patients for that? And do you think it makes their quality of life better?
That's an excellent point, because normally in this preoperative outpatient clinic, my work is to speak against no bladder, because all the patients are coming with the idea that, of course, you take out the bladder, you put another bladder, that's over.
Yeah.
And so I'm critical against that, and I want them to fully understand what does it mean in terms of quality of life, in terms of management, in terms of everything. And then if it's oncological safe as possible, I offer it, but I want them to fully understand and to fully agree and to fully understand, because it's not for everyone. Oh. And what we saw doing recently, we did a survey about the practice in referral center in Europe, and we saw that actually neobladder are decreasing. We are not offering neobladder as much as we were before, and that I think it's important, because I think if you involve the patient and you explain exactly what neobladder is, many patients are just saying, no, thank you.
I don't take it,
I don't want it.
But I think also in that, the patient associations help a lot.
Yeah,
well,
because,
that's right. That's
because they can see how others do, like, okay, they meet somebody that they have had a neobladder for 3 years, and they are like, oh, they are not happy, then why?
Our patient association has a specific WhatsApp chat also for diversion. So there are the neobladder chat, the ileal conduit chat. And here there is some time that I tell to my patient is that they can also be in contact with someone extremely happy, has a perfect neobladder, can also not be the case. Can be like night incontinence, the need of self-catheterismus, can be many other things. So it's very important to be in touch, but we all have a very good history and very bad history of outcomes that we had for our patients. And it's like to present a clinical case with a specific result, then it's not sure that your patient will have the same. So if the patient really understands the risk of neobladder, I'm happy to do it. But that's a very important counseling for the patient.
And it's great, because I think during the discussion we're talking about all things, and we not discussing something is something that can so easily be done. So just moving on, so we've talked about BCG, we've talked about surgery. I mean, for that patient that comes in, doesn't have any of the red light features that we're super concerned about, but BCG has not worked. It's second line therapies. So, I mean, do you do augmented intravesical therapies in your practice? What do you think about the evidence?
You mean the subsequent therapies or BCG unresponsive, right?
Yeah, that's right.
Yes, the problem in Europe is we don't have that many options.
Okay.
I mean, in the US, there are more approved options. But here, so far, we have GemDose, like on a sequential manner.
Yeah.
And since retrospectively has shown to work quite well.
Yeah.
To be honest, in my hospital, it's quite difficult because you need help from pharmacy in order to be on board to get it diluted, the Cetaxel. So it has some challenges. I mean, in my case, that's the issue that I find. What I also think it's important to remember is that there is a window period where it's safe to do any subsequent therapy. So far, we don't know which one is the best to offer. What we can offer is gem-dose, but we don't know yet whatever works best with the other ones that are available that we don't have in Europe yet.
Yep.
But it's important to remember that one subsequent therapy is safe. There is a window period, and if we delay the cystectomy for around a year, it's safe in terms of progression. Mm-hmm. The patients get the same rate of progression if they have a salvage cystectomy after one line of subsequent therapy than if they get it up front, which is something that I think it's important to counsel. They understand it, and they take this risk of progression as normal. Mm-hmm. However, going further, we know that further therapies are not successful, and the risk of progression keeps increasing. So I think it's important to counsel that.
And so for you, Marco, I mean, can I ask you about sort of hypothermic mitomycin or treatments such as that? I mean, what's your feeling about that and the evidence?
So this is something that we offer in our hospital that we have. There are data, also a prospective trial published in European Urology some years ago, and saying, okay, that can be a viable option. I have to say that in the recent years, our use of the technology is decreasing because of all the trials that we have on this field,
other drugs,
with other drugs. And I also want to say that I think that in this period, it's if you offer radical cystectomy in your center, it's very important to have a bladder sparing option for this patient and to offer other alternatives, or to refer the patient to center having this trial if you are not having this trial in your center. Mm-hmm. Because there are now many recruiting trials all over in Europe with several different type of drugs. And it might be sometimes challenging to recruit them because they require some time to have carcinoma in situ or to have a good exposure in BCG, or the relapsing not to be too far away from the last treatment with BCG, or for example, not having a tumor in the urethra or in the ureter. But still, for this reason, we also started to offer gem-dose. That is more like now it is in the off-label setting, so it allows us to offer it to all other patients not being able to accrue them in the trials. But I think it's important to have these options.
And can I ask you just specifically about side effect profile and quality of life? So with gem-dose, what's your thoughts about that? Do the patients tolerate it well? Do they not tolerate it well?
Well, I have to say that I was surprised how well tolerated it was in the patients. From the original publication, and also talking with the expert from the University of Iowa who started with the treatment, that might be helpful sometime to adjust the pH of the urine with the bicarbonates before of the treatment. We're starting to do that. But actually now we are not doing it anymore because we saw that actually it's quite well tolerated. We had 40 patients under treatments and no one discontinued the treatment because of side effects. What happened in some patients, and I think now we have 8 patients with this condition, that they have lots and difficult to keep the drugs inside of the bladder, because with the gem-dose you need to put a catheter, to put the gemcitabine first for 90 minutes and then to change the drugs. And normally the patient can just go out with the catheter and stays, but this patient has a sort of overactive bladder and cannot keep the gemcitabine, and so they need to stand to lay on the bed and you
with the
catheter, and so basically you have your patient clinic busy for 3 hours for one patient. Yeah. That is a kind of a logistic problem, but if you do like that, I have to say in my experience in my center is very well tolerated.
And just finally, I mean, radiotherapy in this group of patients, there was a time with the evidence where we thought it was not possible at all. We've just opened a study in the UK called TRAIN. Any thoughts about that or reflections for the audience? Carmen, would you
in
want to go
terms
first?
of radiation for these patients?
Yeah, any role? No.
So far, we don't have much data, so that I wouldn't encourage it.
Yeah, not outside of the trial.
Yes.
Yeah, no. Okay. So, Carmen, you work with patient groups. Marco, I know you do the same. What are the messages that are coming through from patients about what they want from a quality of life perspective?
So definitely they want to keep their bladder. Yes, that's their most important concern. But also you need to balance the progression rates and the quality of life. So it's a difficult balance.
Okay.
Also, I think it makes a difference where you practice. Like if you practice in Europe, we don't have the financial toxicity issue. That is another concern for American patients. So there are a lot of things that come in the configuration to decide when to move forward in those settings.
Okay. And Marco, I mean, in your experience, what do your patients want?
So I'm also very biased because we are a referral center, and normally I get second opinion for patients who are already very focused on keeping their bladder. And but I think in general it's very rare to find a patient who want to receive a radical cystectomy. The only situation that I can recall is this very huge tumor with carcinoma in situ and lots. The patient will need to go to the toilet every 30 minutes, and their life is really miserable. So in this case, radical cystectomy must be on the table. You always need to discuss with the patient. That is an option, but you also need to have all these other options. And I think, in my opinion, right now with the data, with the trials, is it safe to delay even after a high-grade recurrence, after adequate treatment with BCG? It's safe to delay cystectomy. If you have one of these options, you need to offer this option to the patients. And this is something that I think it's very important to do.
So can we start to talk a bit about the future and where we are with evolving therapies? I mean, there are some excellent studies that have come out, Keynote 057, and any thoughts about that, for example, and emerging treatments? I don't know who wants to go first, but you know, I think it's important we discuss where we're going.
For me, if you ask me about IV immunotherapy, that's what is. So we have the Assoc and the Keynote, Tezo and Premier. I think that has moved to the end of the street, I would say, and timeline, because of the side effects, and the results are not as good as you could have expected. So most of the studies in this area of the disease, they look at response rates, complete responses. And what we see over time is that they keep decaying. So I think one of the challenges is going to be to figure out which drug maintains the longer, but we still haven't had enough time on the trials to actually see what is the reality and the ones that are intravesical. So that's why I think we are moving IV immunotherapy to the end of the line.
Fair enough. Marco, thoughts?
Well, I think it's for this type of patient, for all the drugs that will come out in the next year, it's important to have a multidisciplinary team. That's is fundamental. It's much more important than how it was in the past, because historically, non-muscle invasive bladder cancer was just a urological topic, and the oncologists were not involved. Now it's important to be together with the oncologist. And I think that might be a problem for several centers, because like if you are in a very small local center, of course, you might have difficulties to reach the drugs, to reach the oncological experience. So we need to rethink and rechange how we treat non-muscle invasive bladder cancer. And then I expect this drug to be approved and effective, at least in BCG unresponsive, because saving a patient for radical cystectomy will be also an important save for the NHS. The real point will be when this drug will come in the BCG naive setting, because now BCG actually works and is cheap, and there will be an important discussion about financial toxicity with all these drugs. But
and a lot of logistical issues related on how the side effects are managed. The other thing I see also with all these trials that are coming in the unresponsive setting is that I see more and more the combination therapies may actually work better than the single treatments. I think it's also something to look forward to.
I think one of the things you alluded to, and certainly the direction of travel in the UK, is actually to have more bladder cancer focused teams. And almost non-muscle invasive bladder cancer in itself is a specialty that's managed. And I think that with all these exciting advances and our recognition of the complexities of the disease, I mean, do you think that's possible to deliver? Do you think that's the direction of travel we're heading in? Because it's multidisciplinary, multiple options, sequential therapies, complicated side effects. That speaks to a disease that needs complex management.
Yeah. It's just, I think in bladder, we are going to go through the same steps as prostate did a few years back. So if you look at it, how it has changed in terms of complexity with all the oral drugs and radiation and all the things that get in the picture, so bladder cancer will go through something similar, yes.
Okay. Well, look, I can always chat to you guys all day about bladder cancer, but we're moving towards the close. So, Mark, any closing thoughts, anything you think we might have left out?
No, I think that the message should be that radical cystectomy has to be discussed and considered for the patient with non-muscle invasive bladder cancer, but cannot be the only option anymore, even in case of very high risk, even in case of high-grade recurrence after adequate BCG treatment. There are many other options. It's important to be aware of this option and to discuss these options with the patients, always knowing that also radical cystectomy can be an option. So it's not that we have to go fully on the other side saying, okay, radical cystectomy is forbidden. No, it's there, but there is many other options to spare the bladder of the patient.
Fair enough. And Carmen, you're often a compass in these situations. We've talked about a lot of studies. We've talked about patients who we manage and the importance of their quality of life, but listening and shared decision making. Any thoughts about studies that are exciting for the future, treatments that are exciting for the future before we close?
So I think, as he was saying, patient preference will also and comorbidities take a very important role in all these decisions. And towards the future, we are looking into incorporating more of this data in not only taking into consideration the oncological results, so taking into consideration also what patients think and how it can be part of the decision process. This is what we are looking for, I think.
So including sort of key patient preference and trade-off decision making.
Pros and cons, and how we talk about it all the time. Patient experience instead of only patient-reported outcomes.
Yeah. So there's an implementation piece and for us to work on. So look, I'd like to thank you guys on the panel for the discussion that we've had, and thank you to the audience for watching, and we look forward to continued discussion and improving the care for bladder cancer patients. Thank you.